Assalamu alaikum warahmatullahi wabarakatuh. Hello everyone and welcome to our first session in this year. We are going to start a talk series, as you know, and I'm very happy I'm going to start with such important topic like valvular disease in pregnancy. I think you all know how important is cardiac diseases are now in our practice, especially that the latest report for Embrace have declared very clearly that cardiac disease is the most common indirect cause of death for a pregnant woman. You know this, right? And I want to add something else that not only the cardiac diseases are the indirect main cause of maternal deaths, but also the cardiovascular diseases are the main cause of direct deaths and the overall maternal deaths. And there's a difference between both of them, by the way. And I want you to take care of it when you are answering a question in the exam. Is he asking me about cardiovascular diseases or cardiac diseases? You got my point? Because cardiovascular diseases are the main direct cause of maternal deaths, while only while only uh, cardiac diseases only, not cardiovascular, okay, is the main indirect cause of maternal deaths. Yes, sure, Dr. Muhammad, I will share it right now. I just want you to see something before I share my presentation. I wanted to start with chit-chatting with you how I can summarize a talk article and how I get the information from a talk article, because many of our dear candidates in our course, they always ask about the summary, and I tell them, of course, you can have it, and you don't need to read the talk article again. Why so? Because when I made the summary, I don't only focus on the points that can come in the exam, as SBA, for example. I'm not focusing only on the percentages or information like what is the most common cause of that, what is the least common cause of that. Not only this, no. When you are reading a talk article, guys, I want you to read it with a clinical perspective, not only gaining information. Like what? When you only read the talk article and you have an aim to gain information, you are going only to recall only like 20% of what you have read, only 20% maximum. But when you read it with a clinical perspective, you are going to focus on the clinical points that help you during your practice. This is very important, not only for the exam, but also for your daily practice, right? But for the exam, it will help you a lot during answering an EMQ, for example. And before you read a talk article, please have a look on this. The learning objective in each talk article give you a hint on how, what, and where you should focus during your reading. And what is your aim after you finish this talk article? So our aim today, inshallah, we are going to understand how the valvular disease can affect the pregnancy and vice versa. And how can I have the optimum antenatal care for my patient? How should I give her the best antenatal care and the best management during labor and of course postpartum? This is my aim, and this is what we are going to focus on, inshallah, in our discussion today. So let's see what is the deal with valvular diseases and why we focus on it so much. And can we meet a valvular case in our daily practice? Yes, of course. Yes, of course. We have many cardiac conditions, by the way, and you should know how you can give her the best quality of management. So let me remind you of sorry. Let me remind of you of what? Of the percentages of cardiovascular deaths in the UK, according to the Embrace, and what valvular heart disease encompassed in the total amount of cardiac deaths. We're talking about 13% of maternal deaths. The first one, of course, is the myocardial disease and cardiomyopathy. This is the latest, by the way. This is the latest. And valvular disease will have the share of 13%. 13%. Okay, I just figure out something. Okay, when you have your patient and you have discovered that she's having a previous history of cardiac disease, and you discovered, for example, that she's having a history of rheumatic heart, you should suspect that this patient is going to have a valvular complication, or a Marfan syndrome, or Fontan syndrome, or Adler-Downer. Many of the syndromes, we are going to talk about it in a little bit. But the most important point is to determine which class your patient is now according to the New York Heart Association functional classification. This classification, guys, this is crucial in your plan of management. Of course, the plan of management is not going to be by yourself alone. It's going to be an NDT. However, you as an obstetrician should know if your patient fall in class 1 or 2 or 3 or 4. Because if your patient is class 4, according to the American Heart Association, she should be advised not to get pregnant from the start. Ma'am, pregnancy is very dangerous to you. It could be lethal to you. And I think in the upcoming slides, you are going to know why. We have two kinds of valvular lesions. Today, we are going to focus on valvular lesions only. Okay? So we have two kinds of valvular lesions. Either it's stenotic or regurgitant. Both of them have causes, both of them have different outcomes, and both of them have common points in management and different points in management. What I need you to remember is the examples of the stenotic lesions and the examples of regurgitant lesions. Why? Because as I told you, when you have a lady with, let's say, Turner syndrome, who can tell me which valvular lesion is common with Turner syndrome? Anyone know? Yes, aortic. Which kind of aortic lesion? He's very susceptible for aortic dilatation, yes. And also, which is more common than aortic dilatation, mitral regurg. Mitral regurg, much more common than aortic coarctation or dissection, of course. So you should suspect it and keep it in your mind. So when we are talking about stenotic valve lesions, the predominant causes are rheumatic heart disease for mitral lesions and the congenital bicuspid valve with the aortic lesion. What is this lesion? This is a congenital lesion that the baby is going to have a bicuspid valve instead of the 3 leaflets of the normal valvular valve of the aorta. Okay, so this lesion is going to make a complication. Most commonly is the superimposed calcification and stenosis, of course. For the regurg lesions, we are talking about many of rheumatic congenital or degenerative disease. It has broad causes, okay? And you are going to know that most of the regurgent valve lesions are usually well tolerated in pregnancy. And this is the good news, except for a woman who is having a severe regurg that led to cardiac failure. Okay, are we good up till now? I just wanted to remind you, this is not from the talk article, this is from the European Society of Cardiology. I like this table so much because it reminds me with every condition which comorbidity I should focus on. So as you can see here, and this is our topic today, in cases of bicuspid aortic valve, we are going to focus on aortic stenosis or regurgitation, and in particular aortic stenosis. In a case like Turner, she is going to have bicuspid aortic valve also. Of course, she's going to have a mitral regurgitation. This is very common, but bicuspid aortic valve is a comorbidity, coarctation, as you all said. We have in Marfan mitral regurg in particular, which can lead to heart failure in severe cases. Some syndrome like vascular Ehlers-Danlos, this syndrome, guys, cannot tolerate pregnancy in most of the cases, nearly all of them. So they are not advised to get pregnant at all. And of course, Fontan syndrome also. Okay, in general, general points about preconception counseling and antenatal care. This should be engraved or graved in your mind. I need to do as minimum ESG, echo, exercise tolerance test in all patients who are having a valvular disease. This is a baseline assessment for their cardiac function. Okay? And this can be an exam question, of course. They should know that they are very susceptible for increased risk of obstetric complications. Like what? Like preterm birth, hypertensive diseases, postpartum hemorrhage, specifically because they are going to have anticoagulation. And that's why they are very susceptible for postpartum hemorrhage. What else? They can have fetal growth restriction. And this is in particular have extreme importance. Why so? Because this is why we are going to monitor the babies of such patients on 4-weekly basis from 28 weeks of gestation. By the way, they are not the only one who is going to have such specific or special scanning for the baby. Many other conditions, if you can remember, who can tell me what comes to your mind? Which other conditions that come to your mind now who need a 4-weekly basis of ultrasound scan from 28 weeks of gestation? Excellent, Dr. Nuha. But not any kind of hypertension. Severe gestation, severe chronic hypertension and gestational hypertension, and any kind of preeclampsia. Preeclampsia, once you diagnose it, you need to do right now a scan for the baby, for the gross scan, which is weight measurement, amniotic fluid index, or maximum fluid pocket, and umbilical Doppler. This package, the gross scan package. Okay? Who can remember another example? This is very important question in the exam, and I think it came for a January exam also. The twins have a specific management, but sure, they are going to have a serious scan from 28 weeks. Yes, Dr. An'am is very close. Any high-risk pregnancy, guys, any high-risk pregnancy is going to need a provisional scan or provisional assessing for the baby from 28 weeks of gestation if it can lead to SGA, any chronic condition or medical illness that can lead to SGA basically is going to need a full weekly basis from 28 weeks. Like thalassemia, like sickle cell diseases, like very advanced maternal age, okay? Like um, a high-risk patient for SGA. You remember the table, of course, for SGA. Okay, so this percentage is also going to be repeated for several times in our talk today. 30%. 30% is the percentage of how many fetus can be affected by the maternal disease severity. So it's a huge percentage actually. Okay, this table, when you are going to read it, and I think it came as a question very back 2016, I think 2016, yes. It was an EMQ asking you about the maternal and fetal risk for each of the following cardiac conditions. And by then, the stock article wasn't there, okay? So we mainly depended on the European guidelines. It was really a silly question. But now I can know why. I can know why they focused on such subjects. Because some conditions you are going to give a relief for your patient and counsel her about that she can take a sigh. We are not the worst. We have a very good condition. Your condition is not the worst ever. You don't have increased comorbidity or mortality for yourself or the baby, like if you have a pulmonary stenosis only, PDA only, mitral valve prolapse, and this is very important because mitral valve prolapse is very common within women, very common, especially in the Mediterranean area. Any woman in the Mediterranean area is very prone to have mitral valve prolapse. I think it's in their genes or something. Okay, and if we have a successfully repaired simple lesion or simply any simple lesion who does not have any history of complications like ASD, VSD, or even an anomaly in the pulmonary venous drainage. Okay, guys? We have another conditions with a small increased risk, like unoperated ASD and VSD, repaired tetralogy of Fallot, and most of arrhythmias. So can a patient with AF get pregnant? Yes, she can. If, who can tell me if what? What should we depend on when we are going to categorize my patient? When should I tell her not to get pregnant? And when should I tell her, yes, you can get through this pregnancy if you want, of course. We are going to depend on what? Symptomatic or not? Yes, of course. But we are going to depend on something I mentioned earlier. Yes, the classes, guys, the classes. The classes of the American Heart Association. Remember? Yes, excellent, Dr. Aisha. Excellent, the classes. Because when I'm talking about a class which is classified as 4, I shouldn't encourage her to go through this pregnancy or even get pregnant. Okay? So even if she's having a simple lesion, but for whatever reason, she's now categorized as class 4. No, you cannot get pregnant. And if she is now pregnant, I'm telling you that this pregnancy is going to be very very dangerous for you and for your baby, and especially for you. Okay, this table is very important. Please go through it, and I have um, made a summary for you. Each lesion and the risk, maternal and fetal risk, of course. Uh, the summary, I think I made it after reading the European guidelines for maternal diseases. Okay, now we are going to talk about each condition. The talk article focused on two conditions, the mitral stenosis and regurg, the aortic stenosis and regurg. Okay, so they say that when it's mild mitral valve lesion, usually it's well tolerated and the pregnancy can go on. But the heart failure can occur in up to 1/3 of those pregnant women. This could be an SBA, and this is very important also during your counseling to your patient. So if I'm talking now, or if I'm reading now, sorry, if I'm reading my talk article now from a clinical perspective, I would see those numbers very important. But if I'm reading the talk article just like a simple reading or for gaining information, okay, I'm not going to retain any of those information. You got my point, I think, right? Because now I need to tell my patient that yes, pregnancy is going to be fine. You can tolerate pregnancy. However, you are at risk to have heart failure 1 in 3. This is very important. And if you have a valvular area less than 1 centimeter square, you are having a risk 1 in 2. Okay, guys, so I'm talking about 2 kinds of women. If she's having a moderate mitral stenosis, she's going to be at risk 1 in 3 to have heart failure. If she's having severe mitral stenosis, which is valvular area less than 1 in diameter, she is susceptible to have heart failure 1 in 2. So this is very important. It's not just numbers. Okay? About atrial fibrillation. Is it common? No. Sustained AF is uncommon. In mitral stenosis, they are not common. They occur in less than 10%. Okay? However, also we should keep in mind that if it happens, that puts my patient in additional risk for thromboembolic events. Okay? If my patient is having a functional class more than 2, and if she's having a systolic pulmonary artery pressure more than 30, this is very important number, severe stenosis, advanced maternal age, she is at risk of mortality up to 3%. And by the way, that happened. And that's why the EMBRACE is focusing on cardiac conditions. Okay? Those predictors are my keys or my helpers in a good antenatal care. Okay, guys? So that's why I should counsel my patient for a suitable contraception and provide her with the long-acting reversible contraceptions, LARCs, if she's having advanced class, like 3 or 4, particularly for no doubt for 4. And I should tell her that the FGR is up to 30%. It's not a joke. Okay? What about aortic stenosis? In cases of aortic stenosis, we have to focus on 1, 2, 3 points. First of them, that aortic stenosis is the commonest cause of left ventricular outflow tract. This is the commonest cause. Okay, so when I having a patient and I see that her vascularity is not okay, and she's having like syncopes more severely, and she's rheumatic heart, for example, I should just suspect that there is a kind of aortic stenosis here. Okay, we have early symptoms and late symptoms, and this is very, very, very important during your examination. When you have something like reduced exercise tolerance, cardiac dyspnea on exertion, those are early symptoms for aortic stenosis. But when you have dyspnea at rest, angina, syncopes, we are talking about end-stage cardiac failure. See how important examination is. Then, of course, I'm going to refer her to do investigations and so on, but you are the first point. You are the first one. The patient is going to ask for help, the pregnant lady, of course. Okay, what about the NT-proBNP? Brain natriuretic peptide now is very useful as a marker, very, very important now as a cardiac biomarker. Even you are going to read about it in another talk article, like cardiomyopathy and infarctions and so on. In preconception period, we can detect the severity of the disease and the risk of cardiac compromise during pregnancy by this cardiac biomarker. Also, it can help us to be updated about the cardiac condition during pregnancy. Okay, it can lead us if the pregnancy progression is doing okay with the heart, or they are not really good, they are not really well together. Also, yes, I remember, this cardiac biomarker is very important in differentiating cardiac breathlessness from another causes. So this is very important in differential diagnosis. It can help us in many ways. So please don't forget about it in your investigations. And it's not considered a basic investigation, of course, not like the ECG and echo. But when I know now that my patient is having a cardiac disease or any cardiac condition, the PNP is very helpful for us, either preconceptionally or during pregnancy. Now, aortic stenosis to be successfully managed. I need to know the condition of my patient, how big the root or the aortic root is, because the bigger the dilatation of the root, the more severe the outcome is. So root dilatation more than 5 centimeters is WHO class 4. And this woman should be actively counseled against pregnancy. Okay, what about the risk of heart failure, like mitral stenosis? There is a risk of heart failure, of course, but here it's more, because when I'm having asymptomatic patient prior to pregnancy, it's going to be okay. But if this patient is symptomatic, it's up to 25%. Okay, those numbers are not like haphazard numbers, guys. We are talking about the lives of pregnant ladies who we are going to tell her you are going to tolerate pregnancy well, and who is not. So symptomatology is very important. WHO classification or the NYHA is very important also. Can we do a surgical intervention for those ladies if they need it? Yes, we can. But for the cases who does not respond for good management or good medical management, it's not going to be our first choice because it has its own risks, of course. So I'm going to manage her medically, and when I do my best and the condition is still not controlled, I can do a balloon valvotomy or valve replacement. Valve replacement is mostly carried out after pregnancy or after termination of pregnancy. But what we can do during pregnancy is balloon valvotomy. Okay. Again, the risk for FGR in general is 30%, in particular with moderate or severe aortic stenosis, about 20 to 25%. But here we have an additional risk for this baby. Mostly ladies with aortic stenosis is having a congenital disorder. You remember the congenital bicuspid valve, right? So there is a risk of transmission of this congenital cardiac defect. It's about 10%. And that's why we should do a fetal echocardiography routinely for those ladies. Okay, so not only she is going to have the regular follow-up that we talked about, 4-weekly basis from 28 weeks, but also we need a fetal echocardiography. Marfan syndrome, Dr. Aisha, is famous with mitral regurg more than aortic stenosis. But aortic stenosis, if you can remember from the causes, mostly will happen with the bicuspid aortic valve. This is a congenital problem. Okay, what about the regurg? The regurg, as you can remember from the very beginning, usually they are well tolerated. Why so? Because, you know, the peripheral vasodilatation and the reduced systemic resistance in pregnancy is going okay with this condition, not like the stenotic lesions. However, again, in moderate to severe diseases and patients who are symptomatic or have impaired left ventricular function, they are very, very at high risk of developing cardiac complications. Of course, we're talking about cardiac failure, 20 to 25%. Here, the FGR is much less. Who can tell why? I think it's a logical result from thinking about it. Why the FGR here is only 5 to 10%, not 30%, like other lesions? Because simply the blood flow to the baby is not really affected. Yes, and Dr. Noah have gone far, but yeah, you got a point, because most of those patients is going to have IVF. No, by the way, you can have a normal pregnancy, natural pregnancy with a cardiac condition. You don't need IVF. Yes, excellent, because there is a good circulation for the baby. The circulation of the baby is not compromised, not like the stenotic lesions, right? But is this the case for all women with regurg? No. Whenever there is impaired left ventricular function, keep this in your mind, that can lead to cardiac failure, the circulation will be compromised. Okay, sorry. They talked about the valve replacement in the doc article, and they mentioned the two types of valve replacement. But what's interesting here, they have like a comparison between the two kind of valves. Which is better? If my patient is asking me now, shall I go for a tissue bioprosthesis or a metallic valve? Before pregnancy, of course, this is optimum to be done before pregnancy. If she needs a valve replacement, she should do it before pregnancy in optimum conditions, to be honest. Okay, the natural one is good in points and bad in other points. So each one have pro and cons, honestly. The risk of cardiovascular complications with the tissue one, of the bio one, is low. Okay, as long as it is functioning well, there is no problem, there is no rejection, the cardiovascular complications is lower. Okay, in the other hand, the metallic one is going to have additional risk in terms of thrombosis and the requirements of anticoagulation. But the tissue one will fail within 10 to 15 years after implantation. So my patient is going to have a repeated surgery. On the other hand, the metallic one can be lifelong. Okay, so this have pros and this have pros, this have cons and this have cons. Which one is usually or like generally better? Of course, the tissue one, if we can have it, if we can have it. Because here the chances to get event-free pregnancy, it's up to 80%. So this is a great chance. Okay, in antenatal management, in particular to each condition, we know the general rules now. We are fine, we're good. Now we are just going to highlight the specific points for each condition. In absence of arrhythmias, guys, and if we don't have significant atrial enlargement or congestive heart failure, or there is no there is nothing wrong with the history of my patient. This means that my patient is really doing good. She does not need the aggressive anticoagulation I'm going to give for someone who is symptomatic, have a history of embolism or left atrial thrombus, or she's having a left atrial enlargement or congestive heart failure. Those women is going to read therapeutic anticoagulation, whether with low molecular weight or warfarin. It's not up to me, it's up to the cardiologist. Okay? For a medical treatment also, we use beta blockers. And if beta blockers are not working, we can go for diuretics. Diuretics are usually safe. The benefits outweigh the risk here. When I'm having asymptomatic mild stenosis, I can see this woman once each trimester. But if I'm having a more severe disease or symptoms, she needs to be seen at least monthly. I think this is very, very important, particularly in part 3. Okay, so again, you are going to find the women who needs anticoagulation here, and the women who are going to need surgical replacement. Of course, those women who are having class 3 or 4 or high pulmonary artery pressures more than 50. If I'm having a pulmonary artery pressure more than 30 before pregnancy, this patient is counseled against pregnancy. But if I'm having this number during pregnancy, like my patient was okay, she was okay, and when she gets pregnant, her condition is getting worse and worse until she reached the class 3 or 4, or her systolic pulmonary artery pressure is now more than or equal 50. Of course, despite medical intervention, this woman needs to have a surgical intervention now. So please don't conflict yourself between this number and the other number, which is 30 before pregnancy. Okay, guys, this is very important, and you are going to face it in questions. When we are having pulmonary artery pressure more than 30, she's going to be advised against pregnancy. But when she's having the systolic pressure more than 50, she needs valvular replacement. What is our friend here? Our friend is the percutaneous mitral balloon valvoplasty, of course. Okay, can we do the valvoplasty during pregnancy? Yes, we can, but it's not advocated. You have to terminate the pregnancy first and then do it. And you are going to weigh the risk and the benefit, of course. Why so? Because we are going to do something called cardiopulmonary bypass. And this bypass, guys, which is going to be undertaken during the operation, carry a fetal mortality up to 30%. So that's why they say that if you can do it after pregnancy, or if you can terminate the pregnancy and then do it, you can do it. But of course, if my patient condition become critical, you know that mother comes first, with no doubt. Mother always comes first. For aortic stenosis, same like mitral stenosis in cases of medical treatment. Again, beta blockers and diuretics are our friend here. We are going to see this lady monthly or bi-monthly according to her symptomatic profile. And of course, again and again, we should assess her preconceptionally and advise her if she can tolerate the pregnancy or not. And if she can tolerate pregnancy, and if the condition is mild, and if she is asymptomatic, she is going to be reviewed every 3 months. The same with the surgical management. And as I told you, where this is not possible to postpone the surgery when we have a life-threatening condition, we have to terminate the pregnancy or do an early delivery, according, of course, to the gestational age. Okay, what about the regurg? The regurg is much easier. We just need to control the overload. You know that the overload in regurg condition will be high. So that will lead to, again, a high preload. And high preload will lead to pulmonary congestion and can lead to more cardiac work. How can we control this? By diuretics. Give her diuretics and she will be okay. Every 3 weeks or 3 months for mild cases. 3 months for asymptomatic cases. Asymptomatic and mild cases. Once monthly for severe cases, moderate to severe cases. Okay. Okay, and as we said before, the repair should be undertaken pre-pregnancy if we can. Ideally, where it's required, the delivery should precede this. Okay. Now we have reached a very important part in the dog article, and I want you please to focus with me. If you were just listening before, I need you to give me your attention, the maximum amount of attention that you can give me. Because the whole idea about managing your patient now is how to give her the best anticoagulation and how to monitor the anticoagulation through pregnancy, labor, and postpartum. This has to do with anesthesia, and this has to do with uh, the mode of delivery, and this has to do with if she's going to have instrumental delivery or not, if she's going to have epidural or not, if she is going to be bridging to low molecular weight or start from warfarin to the end, or what should we do? What should we do? So please give me your attention now. The anesthesia in those patients, guys, are very tricky, very challenging. Why so? Because we are talking about a patient who is on long-term anticoagulation. From the start of pregnancy, or maybe before pregnancy, she is on anticoagulation. So we have high risk of bleeding. We have high risk of anesthetic complications. Also, not only that, I'm talking about some woman who is having a problem with her preload or afterload. So how she can cope with the hypotension caused by the anesthesia? Can you imagine this? So we need to avoid the hypotension as much as we can. And that's why the MDT is very important in the management of this lady. First of all, as a general rule, we are going to use invasive monitoring for them during labor to detect real-time changing in blood pressure. And if we are going to use epidural or spinal anesthesia, we are going to use the lowest dose possible, or make a low dose combined spinal epidural anesthesia. They call it CSE. And by the way, this is the best for any woman, not even for the cardiac patients. Combined low dose spinal epidural anesthesia is the best. Okay, but in those women in particular, we need careful titration of the dose. I don't need this patient to go for hypotension. It will be lethal for her. Okay, we can reverse to general anesthesia, of course, if I'm having a severe lesion or I'm having uncontrolled hypotension. If I have to choose between epidural or spinal component is the preferred one. Okay, and as a general rule also, the heart rate should be maintained in that lower range, okay, to make a better coronary artery perfusion in diastole. if anything of what I'm saying is not clear for you, or you have forgot many about the physiology, I can remind you. It's okay. Just tell me. Okay, guys? You get the physiology and how we are going to monitor the heart rate and keep it down and avoid hypotension. You got this, because this is very important. You got why we need to avoid hypotension, why we should keep the heart rate low. Because simply, if she's having a tachycardia, that will compromise the coronary artery perfusion. So the cardiac muscle will get ischemic. We are going to have myocardial ischemia during labor, acute one, okay? So that's why we need her to be as low as we can, as low as we can, and avoid to get her hypotensive as we can. Of course, with maintaining the analgesia. And that's why it's problematic. It's very challenging. Okay, for regurg lesions, because they don't have such a problem with the preload, not like the stenotic lesions, of course, we should avoid bradycardia that can happen during high spinal block. Okay? Otherwise, she is going to be very fine. Okay, now the anticoagulation, and this is important for both part 2 and part 3. I'm just going to remind you with some general rules again, and then we're going to talk in details about how to monitor your patient during pregnancy. In general, we know that we should stop any therapeutic anticoagulation 24 hours before epidural or spinal anesthesia, right? And of course, for prophylactic doses, we should stop it 12 hours before epidural or spinal anesthesia. But now we are talking about therapeutic doses, so we should stop it 24 hours. Again, if you are going to have a patient in emergency situation, like a patient who comes in labor, within 24 hours from the last dose of low molecular weight heparin, what should I do? The best thing for her will be PCA, remifentanil, okay, with recourse to general anesthesia if she is going for CF. I think this is crucial information. General anesthesia if she's going for CS, but if she's having a vaginal delivery, we can give her PCA with remifentanil for pain management. Okay, if you are going to do induction, what should we do? This was mentioned in NICE guideline in details. The preferred mode of labor analgesia would be epidural or combined epidural and spinal if you are going to induce this patient for labor. And in a minute, I'm going to tell you what to give, when to stop, when to start, and everything. Just need you to remember, if your patient is taking warfarin, her INR should be less than 1.5 before institution of neuroaxial anesthesia. Please keep this in your mind, because most of us know that the ideal range for INR for a patient who is on warfarin is 1.5 to 2.5, right? But I need you to keep it less than 1.5 before institution of neuroaxial anesthesia. Okay, they are telling you that this is our main aim. Our main aim to maintain the heart rate adequate for the lesion, avoid hypotension, strict fluid management, of course, in cases who are very susceptible to pulmonary edema, adequate cessation of anticoagulation, and that's what we are going to talk about now. I brought you this slide to remind you about the warfarin syndrome. And by the way, the fetal warfarin syndrome is overrated. Warfarin, when needed, it should be given without any doubt. Should be given because it has very good profile of control. of thromboembolic lesions. But we should, if we can, we should stop it from 6 to 12 weeks, because this is the highest risk for congenital anomalies. Okay, what are the overall rate if we give her warfarin in the first trimester? 5 to 6%. But most of patients who start warfarin, mainly we are going to bridge them to low molecular weight heparin. Low molecular weight heparin is of course safer in terms of congenital anomalies. However, it carries a risk for thromboembolic complications more than warfarin. So when your patient is going to ask you about which is better, what should I go for? Should I keep taking warfarin, or should I go for low molecular weight heparin? What do you think? Do you think it's an easy question to answer? Is it a yes or no question? Like, can I have low molecular weight instead of warfarin? You think it's easy to answer this question? Actually, no. Actually, no. It's not easy at all. Yes, excellent. There are pros and cons for each one. Pros and cons for each one. I will leave you with the recommended peak of anti-10A levels and so on. But I need you to tell me why we need monitoring for those cases. Because I remember I have read this question from some candidates one day. They say, we have always known that low molecular weight heparin does not need monitoring. So why they told us here that we need to monitor this patient and keep the peak of activated anti-10 levels at 0.8 to 1.2. Yes, excellent. Excellent, mashallah. Because we are talking about a therapeutic dose. We are talking about a severe case, a case who is susceptible for bleeding and also thromboembolic events. And that's why we need monitoring here. But in general, low molecular weight heparin does not need monitoring. Okay? And that's why they say it should be trough levels. Trough levels may be also beneficial. Means you should be judgmental when you deal with the levels of anti-10 with those patients of low molecular weight heparin. Okay, take the most attention in the first trimester, because the thromboembolic complications happen in the first trimester with those ladies. Not like other ladies who have risk factors for VTE. They are most prone to have thromboembolic complications during the third trimester and postpartum, peripartum, right? So those ladies are unique. Okay, we have 3 strategies. Those are the 3 strategies that we can encounter in our clinical practice. The first one is a woman who is having vitamin K antagonist. It was mentioned like this in the talk article, by the way, VKA, throughout pregnancy, or a lady who is going to have a low molecular weight heparin in the first trimester, then warfarin in the second and third trimester, or a woman who is having low molecular weight heparin throughout pregnancy. Okay, guys? So VKA throughout pregnancy, she needs to bridge to low molecular weight heparin. Ideally, once she knows she's pregnant. But some other ladies will need warfarin. They are best controlled on warfarin. So they are going to continue warfarin throughout pregnancy and stop it 2 weeks before delivery. Of course, with much monitoring to the baby and to keep eye on whether he is developing warfarin syndrome or not. Stippled epiphysis and cardiac manifestations, PDA in particular, okay, the depressed nasal bridge, and so on. Okay, the other one is low molecular weight in the first trimester, then warfarin in the second and third trimester. When she's having the low molecular weight, she's going to have it twice daily because it's therapeutic, and the VKA is going to be stopped before 6 weeks and returned again after week 12, then stopped again 2 weeks before delivery. I'm going to give you a timeline now, but don't worry, but just focus with me. This is the most complicated one or with so much details, but the first one, warfarin throughout pregnancy or low molecular weight heparin throughout pregnancy is not a problem. Low molecular weight heparin is continued until delivery, and I'm going to stop it by how much hours before delivery? If you can remember. When should we stop the low molecular weight heparin before delivery? In this case, 24 hours, excellent. And what if I'm going to give her induction? Anyone knows? Anyone? Okay, it's a little bit tricky. A day before? No. A day before is 24 hours. Oh, okay, you are answering the previous one. Okay. Okay, guys, take care that 24 hours we are talking about epidural and spinal anesthesia, right? So I'm not talking about normal vaginal delivery or induction. It's different. And I'm going to tell you what should we do in those cases. So that's what I was talking to you about before. During your counseling, can you say that a specific regimen is ideal? No. Can you say that low molecular weight throughout pregnancy is better than warfarin? No. No, you cannot say so. It's according to this woman. Every case is individualized in her follow-up. Okay? And you should tell her, you just need to know the basics. What are the basics? The basics are low molecular weight heparin carries higher risk for thromboembolic complications, but they are having low congenital anomaly profile or no congenital anomaly profile. However, in case of warfarin, yes, it has a congenital anomaly profile, but it's better for controlling the thromboembolic complication. On the other hand, if you are having warfarin more than 5 milligram per day, we should advise you greatly that you are going to have a warfarin imperiopathy, sorry. I like to call it fetal warfarin syndrome. Okay? So if my patient is having warfarin more than 5 milligram per day, that means that she is at high risk for warfarin syndrome. Can I bridge her to low molecular weight heparin? Yes, I can. But it's not going to be my call alone. It's going to be my advice plus the cardiologist advice, a specialist cardiologist advice, and If there is a obstetrician who is interested in cardiac cases, of course, he can be a part of the MDT. And moreover, the patient herself, because she is going to be the one who is having daily injection twice daily. You have to keep this in your mind. This is very important, guys, during counseling. The impact of each regimen on the woman's quality of life. If you are going to advise low molecular weight heparin for this patient, you are telling this patient that she is having twice daily injection and several visits to the hospital for blood tests, right? So she should be a part of this discussion also. Okay, intrapartum care and mode of delivery. As a general rule, again, when you have a mild case, asymptomatic case, no cardiac compromise, the output is okay, there is no heart failure, you can go for vaginal delivery. Okay, speaking with the classes, when we have a class 1 or 2, we can have a vaginal delivery. Class 3, it's a gray area somehow. Class 4, of course, you are not going to make her strain or have the pain or the cardiac compromise during the third stage. Not so ever. She's going for directly for cesarean section. Okay, so and they remind us again that mild or moderate dysfunction, especially those not on therapeutic anticoagulation, can have vaginal delivery peacefully. Okay, should I tell my patient that you should have instrumental delivery in the third stage? Second stage, I'm sorry. Is it a must to use instrumental delivery? No. Consider, and I think if our candidates remember well, they have told me about a question that came in January. It was an EMQ about a cardiac case. I'm not sure she was cardiomyopathy or infarction, and there was many choices between whether to deliver her vaginally or cesarean section, whether to give her instrumental delivery or not. Are you going to not to use epidural or not? Many choices. I told them, I think they are not they don't need you to know specific details about this condition. They are asking you in general. In general, you should advocate your patient for vaginal delivery if she is asymptomatic or have a mild condition. If she's having, for example, MI recently, you know, from the previous talk article about MI, you should postpone delivery by 2 weeks, right? But does that mean that every patient with MI should have a cesarean delivery? No. Yes, it's better to shorten the active second stage, yes. But if she's having a good progressing labor, if she's having good descent, good dilatation, everything is going okay, why should I use instrumental delivery? It's not a must. So just go for the option of postpone delivery by 2 weeks and look for vaginal delivery or induce her after 2 weeks, and she can go in this way or she can go in that way according to her condition. Who knows? Maybe she is going to have um, any obstetric reason for cesarean delivery apart from her cardiac condition, right? You got my point. Yes or no, guys? Okay. So when we should advocate emergency delivery for which patient? Emergency cesarean delivery. If this patient is having active labor while she has been taking warfarin within 2 weeks. And I think we have said it before, right? Because she is at high risk of bleeding, particularly intracerebral, even for the fetus. Even for the fetus, the fetus is not going to maintain, or let's not maintain. He is very at high risk of having intracerebral hemorrhage during the head passage, during the vaginal passage of the head, right? So that's why if my patient comes in active labor when she is taking warfarin within the preceding 2 weeks, I'm going to deliver her by cesarean section with closed liaison, of course, with hematology and with careful uh, handling of the baby. Okay. What about endocarditis risk? They said that those women does not need antibiotic prophylaxis because anyway, if this patient is having a cesarean section or instrumental delivery, she's going to have antibiotic prophylaxis. But for a person or for a woman who is having a personal history of infective endocarditis, she may need a specific additional prophylaxis. What about the third stage fluid shifts? This needs a little bit of physiology revision in a hurry. I'm not going to talk much about it. You should monitor your patient carefully, specifically in third stage, because there is something that will happen in third stage that is very lethal for a patient, specifically for a patient with mitral stenotic lesions. Why so? Because we have something called autotransfusion. When the uterus involute, the uterine involution happens, autotransfusion from the uterus to the heart happens. And this means I'm having more preload. More preload means more blood in the ventricles and the diastole. And I'm having now a mitral stenosis. So that means I'm making my atrial and ventricles compress themselves more and more. That can lead to acute heart failure. That can lead to myocardial infarction, acute myocardial infarction. That can lead to severe pulmonary edema because the afterload is going to be increased also. How I can manage this? By diuretics. And I have to balance between the preload and afterload. On the other hand, I need to maintain a good cardiac preload in women with aortic stenosis. Those women are going to have a very low afterload, right? Their afterload is already low. So can you imagine if this patient is having hypotension now? I'm killing her. So I need to maintain a good cardiac preload. How is so? By maintaining good fluid intake. So those cases, guys, are always, I don't want to say difficult, but they are really challenging because you are balancing between giving fluids or not giving fluids. Should I give now or shouldn't I give now? Should I increase the fluids or not? What about oxytocin? Should I give oxytocin or go for misoprostol? Is it safe to give ergometrin or not? Of course, ergometrin and carboprost is not our friends here. So you can go for oxytocin, and you need to go for what we call it concentrated oxytocin infusion. This regimen is initial infusion at 1 to 4, milliunits, which is 2 to 8 drops per minute. Then increase it at intervals, mainly 20 to 30 minutes, until you reach 1 to 2 millunits per minute. You can do so until you have adequate contraction pattern, like similar to the normal one. Okay, this is what they mean by concentrated oxytocin infusion. Misoprostol is safe. Yes, it's safe, but it can increase the cardiac output. It's a common side effect of misoprostol. So, is it good for someone who is having, let's say, mitral stenosis? She's going to have a huge preload. No, it's not good. Okay, I think we are reaching our end of discussion. I'm going to remind you when to start and when to stop the anticoagulation. This is not mentioned in the TOG article, of course. They mention it in a hurry, but and thanks to Dr. Ahmed Ghubara, he had drawn this beautiful timeline. Warfarin should be stopped 2 weeks before anticipated delivery or elective CF. Okay, and when we do so, we are going to move our patient to therapeutic low molecular weight heparin. She is not going to be free from anticoagulation those 2 weeks. No, this is called bridging. We are going to bridge our patient from warfarin to low molecular weight heparin with the recommended peak anti-10A levels, okay? And if she is on target, we are going to monitor her weekly. If she is off target, we are going to do daily monitoring. Then we are going to stop the low molecular weight heparin 24 hours before the CF. And then again, we are going to start it 4 to 6 hours. If there is no epidural, if there is nothing, you are going to start it 4 to 6 hours. And then restart the warfarin again after 7 days. Is the timeline clear, guys? Do you think it's clear or need more clarification? Okay, thank you, Dr. Ibrahim. The induction, I'm going to tell you about induction, Dr. Noha, don't worry. Okay, here, for a normal vaginal delivery. Again, the warfarin is going to be stopped 2 weeks before the anticipated birth. And you are going to start the therapeutic low molecular weight heparin 24 hours later from the stoppage of warfarin. Here is your question, Dr. Noha. The birth should be within 12 hours of the last dose. This is ideally. But the closer you can, please do it. In means of what? If you can stop it 4 to 6 hours before delivery, do it. If you are not going to use instrumental delivery or nothing, because this is your judgment. This is your judgment. Ideally, you should stop the low molecular weight heparin 12 hours before birth. It's now your judgment, either to continue on the injection, okay, or transform your patient to unfractionated heparin, IV infusion. IV infusion has better control because you can stop it 4 to 6 hours only before active birth. So when you are going to start induction, you are going to ask yourself, am I going to stop the low molecular weight heparin injections, or should I move my patient to unfractionated heparin and monitor her? This is your choice according to her condition, according to the progressive labor. You got me? According to whether you see that she is going to need instrumented delivery or not. It's a little bit tricky, yes. Can anyone tell you for sure what to do before 2 hours of active labor? No one can tell you this. No one can tell you this. But you have the choice whether to continue on enoxaparin injections shots or to convert her to unfractionated heparin IV. Again, after birth, you are going to restart the low molecular weight heparin 4 to 6 hours after birth, and then restart the warfarin after 7 days. What about someone who is going to have epidural? The same, but of course, we are not giving doses while the catheter is in. And after the removal of the catheter, we are going to give her a prophylactic dose of low molecular weight heparin, not the full therapeutic dose. I'm telling you now, by the way, when we restart low molecular weight with prophylactic doses in cardiac patients, we are talking cardiac patients are not going to have a prophylactic dose. They have therapeutic dose. Okay. Second, Dr. Aisha, yes, we are going to restart the low molecular weight heparin 4 hours after removal of the catheter. But which dose? Therapeutic? No. We're going to give her prophylactic dose first because she is still in high risk for epidural side bleeding. So we are going to start with prophylactic dose. Then after like 8 to 12 hours, we are going to start the full therapeutic dose. Another tricky number is, when should you start the low molecular weight heparin after delivery? 24 hours of the last dose. This is ideal. This is ideal. So let's say my patient has her last dose at 6 p.m. Okay? Okay, and she's now having her epidural, active labor, what so on. She had delivery by, I'm going to be optimistic. Let's say 3 a.m. Okay, she had delivery 3 a.m. Okay, guys. So now I'm going to do what? To remove the epidural catheter, then wait 4 hours, and then start prophylactic dose. Then after 8 hours, I'm going to start the therapeutic dose. Let's count now. 8 plus 12, sorry, 8 plus 4 is 12, and 3 a.m., 6 p.m. to 3 a.m., 6 hours, 9 hours. 9 hours. So it's like, ya Allah, I'm so slow. It's like 21 hours from the last dose. 24 hours from the last dose. Am I okay? I am perfect. I'm perfect. But if it's more than 24 hours, I'm at risk of embolic events. I wish I'm clear. I wish. And I'm sorry I'm so slow with calculation. Really, really slow. You got the idea. Please say yes. Not really. Okay, I will calculate it again, but let's see uh, how many slides are left. Okay, here for a therapeutically low molecular weight heparin, spinal anesthesia. Okay, let's calculate it again. I know it's not easy, I know. Okay, and instead of my poor handwriting, I'm going to do it like this. We have a therapeutic low molecular weight heparin stopped 24 hours before the spinal anesthesia, okay? Okay, so it's now 3 p.m. Stopped low molecular weight heparin. Then we are going to wait 24 hours, right? So we are going to start 3 p.m. next day, spinal anesthesia. Okay, she's now fine. She had delivery. Everything is okay. When should I give her again the low molecular weight heparin? She went from the delivery room by 4 p.m. When should I give her low molecular weight heparin? Yes, excellent. Excellent. 8 p.m. The next one will be 8 a.m. 8 p.m. Sorry. Yes. Not before 4 hours. Yes. Should I start with therapeutic dose or a prophylactic dose? Yes, better a prophylactic dose. Then I will switch to the therapeutic dose 8 to 12 hours later. When I start my therapeutic dose, it should be after 24 hours from the last dose, from the last therapeutic dose. So when I'm going to start my therapeutic dose, this one is prophylactic, okay? Okay, now I'm going to start my therapeutic dose after, we will make it easy, after 12 hours. So I'm going to start new therapeutic dose at 8 a.m. When we have stopped the last therapeutic dose, 3 p.m., right? The next one should be started ideally 3 a.m., not 8 a.m. Ideally. You got it, Dr. Ibrahim, now? I assume that I'm going to start 4 p.m. was the prophylactic. Then 8 p.m. No, sorry, 4 p.m. Delivery. Okay, 8 p.m. the prophylactic, 8 a.m. the new therapeutic dose if I'm going to give her after 12 hours. So I'm asking myself, when was the last therapeutic dose? It was 3 p.m. yesterday, right? So ideally, I should start my new therapeutic dose at 3 a.m. I have a range anyway. I have a range to start the new therapeutic dose 8 to 12 hours. Clear or not? This is prophylactic. Okay, after 8 to 12 hours, I start therapeutic. Okay, so ideally I will start the new therapeutic dose at 3 a.m. Exactly. From the last therapeutic dose. The new one should start 24 hours from the last therapeutic dose. And you are the best doctor on this planet if you can do so. Hopefully all of us we can do it, inshallah. Okay. I think we have reached our end. Yes, this is when you are going to use the unfractionated heparin. Intrapartum, you are not going to use any kind of anticoagulation. You are going to be on the effect of last dose of either low molecular weight heparin or unfractionated heparin. You mean during labor? During labor, right? During labor, the active labor, there is no unfractionated heparin. You are going to stop the infusion 4 to 6 hours before active labor. Here, if you are going to use the unfractionated heparin, you are going to stop it 4 to 6 hours, okay? If you are going to give her shots, low molecular weight heparin shots, stop it 12 hours before normal vaginal delivery. Why many doctors prefer unfractionated heparin, especially in patients who need inpatient management? They need to be monitored, and of course, all of our cardiac patients today is going to be inpatient management. They are going to deliver in the hospital, right? So unfractionated heparin gives me the advantage of stopping the infusion very near to delivery. This is one. It has an antidote, excellent, right? And I can monitor it, right? The platelet count, don't forget this. This is an exam question, very familiar in part 2. Platelet count should be monitored every 2 to 3 days from day 4 to 14. Yes, excellent, by platelets. We're going to do a platelet count every 2 to 3 days from days 14 to 4 to 14 after delivery. APTT for warfarin. Okay, and I have brought you the table from the other talk article also, the Pridgen. We should keep it from 1.5 to 2.5 during treatment, but who can remember the ideal INR for warfarin before epidural and spinal anesthesia? Excellent, Dr. Ashley. It should be kept less than 1.5 before the institution of epidural or spinal anesthesia. MashaAllah, you are awake. MashaAllah. Lactation is encouraged. Nothing is wrong. Even if she's taking warfarin, you can tell her that it's safe. because the inactive metabolite of warfarin is secreted in the milk. Contraception is really easy because we are talking about someone who is having thromboembolic risk. So of course, I'm going to stay away from COCs, any kind of estrogen in this world, and keep my choices between IUDs or progesterone. They say that uh, a progesterone implant or IUDs can be fitted at the time of elective cesarean section, which is really good. You know that we can do IUD fitting during CS, right? And also you can do a progesterone implant at the time of elective CS. Mirena will be perfect for those ladies because not only it's going to be a contraceptive for them, but also it will control the menses and get it down, get the flow down, because they are on anticoagulation, so they are going to have a heavy menstrual bleeding. Last but not least, this is a case the Embrace put it in her report, the last one. It's a case of an older woman with a past history of metallic mitral valve replacement and on warfarin anticoagulation, had confirmed pregnancy at 6 weeks. She was unsure if she should continue the pregnancy or not. She was seen for specialist hematology assessment and the warfarin was changed to tinzaparin. Termination of pregnancy was discussed, but before this could take place, she had a thromboembolic stroke. Thrombus was identified on the mitral valve. She deteriorated and died a few months later. This is a case, a real case, a tragic case that should make us keep our eyes open on any cardiac case, guys. Any cardiac case, valvular or not valvular. Any cardiac case, we should give her our most attention. They have attributed this death to the lack of documentation of contraception or pre-pregnancy planning. Yes, she had regular monitoring. Yes, everything was okay with her GP. But there was no documentation of contraception or pre-pregnancy planning. And this is very, very important. And that's why women using oral anticoagulation with warfarin or Duax or whatever may be more safely management without transition to low molecular weight heparin treatment when having an early termination of pregnancy. So the decision whether to continue this pregnancy or not should be taken quickly. The decision whether she has to get pregnant or not should be made pre-conception. This is ideal for the maternal lives to be saved. I have reached the end of my discussion. If you have any question for me, you are mostly welcome. Any question? Any conflicts? Okay, anything not clear? Yes, the PDF is of course available in our course module in the website. Thank you so much. Thank you, guys. Really, no questions? That means either you really got it or you don't get anything. Okay. Thank you so much. Inshallah, we are going to meet again soon. Thank you so much for your time, guys.